Good afternoon, everyone. I hope you're having a great learning experience so far. India faces unique challenges to make healthcare and accessible to every citizen, including vulnerable and marginalized populations. In this session, let's hear on how technology has scaled to key national health platforms such as Ayushman Bharat Digital Mission and Pradhan Mantri Jan Aarogya Yojna to solve country's biggest healthcare problems. Please welcome on stage Mr. Samarth Mason, Business Development Leader, Healthcare at AWS, to facilitate the panel and introduce our panelists. Over to you, Samarth. Thank you.
C body.
No, it's just the name of God. Like,
Thank you, Dechika. Hi, everyone. Good afternoon. Very warm welcome to the panel on healthcare. We have a power-packed panelists group who are participating on the panel today evening. Not tonight. Yeah, still some time for tonight. Let me begin by introducing the panel and start welcoming them on stage one by one. Our first panelist is an AI scientist and the founding member of Cure.ai. He has been working at the intersection of AI, computer vision, and healthcare for the past 7 years. His team of 20 AI scientists develop algorithms that power Cure's healthcare AI products. Cure.ai has been solving problems in radiology by enabling AI on radiological images and preventing lung cancer, stroke, tuberculosis, and heart failure. Please welcome Mr. Preetham Putha. Our next panelist is the lead for digital in the India office of Bill and Melinda Gates Foundation. In his role, he is responsible for the technology interventions required across the foundation's programmatic work in India. His current work is focused in driving digital health mission in India, working closely with government. Please join me in welcoming Mr. Sohail Bidani. Our next panelist is the founder of Plus 91 Technologies. He actively consults on a variety of private as well as public healthcare projects in India, Ghana, Nigeria, and United States. In a career of over 17 years, he has worked on projects in the areas of improved information therapy, EMR adoption, syndromic disease surveillance, healthcare, and the list goes on. He's already here on stage, Mr. Nip Nelani. Our next distinguished panelist has over 17 years of experience in health informatics domain. He's been a pioneer in establishing a number of national and international telemedicine networks in India, Myanmar, Tanzania, Armenia, and Kyrgyzstan. He has coordinated training over 2 lakh doctors and paramedics, healthcare ID staff on e-health solutions from over 70 countries. He has been instrumental in building and scaling national telemedicine platform eSanjeevani. It's my pleasure to welcome Joint Director, Health Informatics and Electronics Division and Program Director, eSanjeevani, Mr. Rajesh Kaushish. And last but not the least, our final panelist heads Strategic Business Development at AWS India Public Sector. Her current focus areas are urban, rural, utilities, geospatial, and impact startups. She has been with AWS since July 2018. Prior to this, she has led smart cities with Microsoft and IBM. Please welcome Deepti Dutt. A very warm welcome once again to all the panelists. As I said, it's a power-packed panel this evening, and we are requesting a change of place for Deepti, I think. Yeah, let's swap places. Perfect. I think Dechika has already set the context, but just to reiterate why we are here today and what we are discussing, we're going to start by discussing the problem statement. How do we get healthcare to the large Indian population at scale, and especially for the vulnerable and marginalized sections of the society? We're going to be spending some time deliberating on the problem statement. Right after that, we're going to start discussing solutions or the how. That's where we're going to talk about how technology is enabling national health programs like the Ayushman Bharat Digital Mission, and how founders sitting here and national programs such as eSanjeevani are interfacing with the government, being facilitated by multilaterals like BMGF to solve this problem at scale and create the digital health ecosystem of India. And finally, we're also going to be learning from our customers on stage on how AWS can be instrumental in inventing and simplifying this mammoth digital health ecosystem journey that we've embarked on. So that's a quick overview of what we're going to be discussing on the panel today. Thanks again, everyone, for joining me on the panel, and we are good to get started. Okay, perfect. Um, we will keep this conversational in case anyone has any question as the conversation is progressing. Please raise your hand and I'll bring you into the conversation. So I'm going to start with Sohail, who represents BMGF. Sohail, the first section of this panel discussion is going to be focused on the problem area. And I'd like you to share, as per you, what are the top 3 challenges that we are facing as we are embarking on the journey of digitization of healthcare in India?
Sorry, I'm audible. I need to do a testing. I'm audible?
Can we do a mic check for Sohail? Yeah.
Okay, working. Thank you. First of all, thank you everyone. I think it's great that we are coming and discussing a topic like this. So very quickly, you asked me for 3 biggest challenges. First and foremost, I think it's inclusion. The moment we talk about digital, there's this general tendency to start thinking about ownership, access, literacy. That has to be the fundamental principle based on which we move ahead on this journey of digital health in India. Inclusion is non-negotiable, and we have to, in fact, ensure that this is designed in a manner where these constraints that we usually talk about are not a deterrent in terms of access to the data information that we're talking about. And I think the previous panel, it was great to hear people like Nayak ji on the COVID success. It's a great example of keeping inclusion in mind. We still managed to cover a sizable population through the same application. Everybody has a certificate. And we all know how great COVID has been for India and what an exemplar it has been for the rest of the world to emulate. I think the second one is fragmentation is a serious concern. Fragmentation in India from a service provider standpoint is, I don't know how many people are aware, but 93% of the service providers in India, health service providers, whether it's doctors or the labs, the pharmacies, these, especially if I talk about the doctor side of things, 93% would be what we call as mom and pop clinics. It's very difficult, right? When you have such a long tail when it comes to the service providers, how do you get them involved in the entire process? Third, which is possibly an extension to the second point itself, is this whole ecosystem approach. Just forget everything else. Just let's talk about people here, right? You and I access health services for various reasons, for our family, for ourselves. Now imagine a situation that I walk into a doctor's clinic, I get a consultation done, I have a prescription from the doctor, which is all digitized, right? So it's available, accessible by me in my personal health locker, which I have. Now I walk into a lab to get my test done, and everything comes in a PDF form to me separately, which is not machine readable. I can't tag it to my health records. Now I walk into a pharmacy to get the medicine where I get nothing in a digital form. It just doesn't work, right? Because as a beneficiary or the patient, I don't see the utility of it. So unless until we get the entire ecosystem adopting digital health, this is going to be a significant challenge for us to show value to all the stakeholders concerned here.
I forgot to mention there's a 6th panelist, which is the elephant in the room, which I call adoption. And we're going to talk a lot more about it. Okay, so inclusion, fragmentation, and ecosystem. These are the 3 problem statements that Sohail has shared with us. Very interesting. I think each of them, when broken down, can be its own panel, and these problems are really, really deep. But let's continue to peel the layer one at a time. I'm going to go to Rajesh ji from CDAC. And my question is that as the R&D and execution institution or the government arm who's building health informatics platforms, e-engineering, of course, is a big success. In these three themes that Sohail has highlighted, which problem area do you relate to the most? And if you can just help us go a little deeper there.
Well, thank you. Thank you so much, the audience, for being here. It is very difficult to be here post lunch and listening to experts speaking things which might not sync up in the same frequency. But I think you yourself answered the question, so I'll go with the elephant here in the room. So undoubtedly, it is not the technology. It is, I mean, yes, theoretically, perfectly pointed out by Sohailji, but I'm a practical man. I mean, unlikely to be in a government sector, but yes. So you talk about adoption. I mean, the technology has been there. It has only been, scaling up, coming up in a different way, in a more user-friendly way. But adoption has always been a problem. So you must have heard, the doctors, the specific healthcare IT, you name the product or the ecosystem which we talk about in a healthcare IT domain, be it the teleconsultation one, the hospital management information system, or for you as a user to go into a pharmacy asking for a medicine, getting it delivered after it is billed. But how many of you are aware that there are ecosystems or laws in the country that even when you go to a pharmacist for asking a drug, so as per the existing norms and things set up by the government, at least for some of the medicines, he's supposed to record that, supposed to pass on that information to the regulatory bodies, but they are not ready to adopt that mindset or the change. So that's a typical end user example from the actual client perspective, but talking about from the other side of the game where when the doctors are used to make. So I'll just take another minute to highlight the very one single worded problem statement which was given to us for the design and development of this now I'll call a revolutionary step by the government of India during the pandemic. We got a call, our boss got a call that you are aware the country is under lockdown, the hospitals are closed, so as the mandate of the Ministry of the Health, we would like you to build up a solution within 2 weeks. That was the time, 2 weeks, to design and develop a patient-centric solution where from the confines of the home, the patient should be able to connect with the doctor. So that was the one liner problem statement, and believe me, I mean, you must have, many of you must have utilized the service, but again, from the adoption point of view, the lacks of doctors which we have trained, the users which we have trained, the single problem which we have otherwise have faced in the field. I mean, that wasn't the time when we were supposed to go to the field, but again, due to the feedback which we got from different ways, the only concern from the practitioners and the providers context was this adoption. But yes, what Suhail rightly pointed out was the entire ecosystem in itself wasn't ready to accept this change, this drastic change. I mean, pandemic have changed our lives for we are yet not clear what path it will take in the another couple of years or down the line. But yes, I think there is a slight change now, but yes, the core or the crux of the problem still lies in the adoption of the system.
Okay, so adoption, I think, is emerging as a clear problem area. I do know a lot of health techs, and we're going to come to them. National level programs have been designed and they are being implemented and they're looking at scaling, but adoption is about change in behavior and it's about product market fit. So let's move on to the founders on the panel and see how they are thinking about adoption and how are they solving for this. So I'm going to start with Preetham for Cure. So 2 questions, Preetham. One, why did you pick the problem area of tuberculosis early assessment, and now, of course, you've laddered your product journey across various other use cases like stroke, etc. And secondly, if you can quickly throw some light on this topic of adoption and what's your, we'll still stick to the problem rather than getting into the solution. That's the next round of conversation, but your validation of this problem statement around adoption.
Right. Got it. Okay, so we in 2016 started out as an AI for healthcare company, and very quickly we realized that radiology is the subset because it has undergone the most amount of digital transformation. So DICOM protocol, which is basically the base of radiology, it was developed in the 80s, even before HTTP, right? So there was a lot of data readily available, retrospective data that was readily available, and as you know, AI is data hungry. So we needed to, I mean, that was the radiology was the thing to work on at that point in time. Also, it was in conjunction with the computer vision revolution that was happening at that point in time, where suddenly deep learning algorithms were able to significantly improve in terms of their ability to analyze and interpret images. Now then, 1 year down the line, we built QXR, which is a chest X-ray solution which could detect the top 10 findings in chest X-rays. And so coming to TB was the first disease area that we picked, primarily because TB is a scale program. So at that point in time, there were WHO guidelines saying that chest X-rays should be used to funnel patients to the further microbiological confirmation test journey, because these microbiological confirmation tests are costly. They cost about $20 after subsidies, and these programs, foundations like BMJF and Global Fund and USAID, they fund them, but then their funds are limited, right? They cannot do this microbiological confirmation test for everyone. So they need a way to funnel these patients to those tests. And at the point in time, they were using clinical symptoms to funnel. And that was a very suboptimal way. And chest X-rays clearly were significantly better. But the problem with adopting chest X-rays was that you need radiologist expertise. And radiology expertise is very rare, right? The whole of India has about 10,000 radiologists. Kenya has less than 100 radiologists. So using chest X-rays was a significant operational problem. I'll tell you an example. But there are some programs who have been using chest X-rays for this funneling. But how it works is, I'll give you an example. So in Philippines, the NTP procured 4 or 5 vans fitted with X-ray machines, and they start in Manila on Monday, and they go around the country for 2 weeks. They collate all the X-rays, come back to Manila again, and the radiologists report it. And then they go back to trace the patients who are suspected of tuberculosis, and then collect the sputum, which is needed for doing the microbiological confirmation test. So you see the operational nightmare that it involves, right? You cannot even trace the patients because 50% they're just lost to follow. So now what we enabled is, with this QXR solution, within 2 minutes we could give a prediction that this is a person who has signs of tuberculosis and you need to collect the sputum. And then they had these gene expert machines in the vans itself. So we brought down the time to diagnosis from about 28 days average to hours.
Sure.
Within a span of 1 month. So that is the transformation that we could, yeah. So in coming to adoption, so adoption is a very real problem. So to reach the scale that we did, we had to integrate with more than 100 different health systems, right? It's not a trivial problem at all. And a company like ours, for it to be viable in the Indian market, the digital transformation that's happening needs to be homogeneous. It cannot be fragmented like it is even in the US at this point in time, right? Yeah.
Very interesting point you mentioned, Preetham, around integrations. I think it's about enabling the user of your product to get more and more value out of what they are using. Yeah. And then I think going back to Sohail's point around ecosystem creation, if each health tech or each solution is going deep in a problem area, can there be a methodology to start integrating around themes and solving the problem from multiple angles? And we'll talk more about it in the solutioning part of the conversation, but that's a very interesting point. With that, I'm going to go to Nrip. So Nrip, on the very interesting, so Plus 91 actually has been one of the first solution providers who integrated with the ABDM, Ayushman Bharat Digital Mission. So what was your approach to pick the problem areas that you did? Like, why did you choose to build what you built? among so many problems that are there to solve in India in the healthcare ecosystem?
All right. Thank you for this event, and firstly, thank you, Suhail, because where you started off, you actually gave part of my answer. Uh, we didn't start when ABDM came out. We'd been in existence for 13 years, purely in digital health, and we kind of had understood that not just in India, globally, healthcare is a very fragmented sort of a ecosystem. I mean, there is no ecosystem. So you have to create an ecosystem. You can't create an ecosystem sitting outside and saying, do this, do this. To be inside it as a partner. And when ABDM happened, so I won't go into our history, but I'll straight away come to the problem area, how we picked it during ABDM, how we went about it, is that when ABDM happened, we looked at it from the point of view that how Obamacare changed digital transformation in healthcare in the US. And we said that, is this possible in India? And we looked at what had happened with Aadhaar, how today we don't pay 5 rupees to the guy on the road to pick up a samosa. We GPay them. So I was like, if this can happen in India, we should be a part of this. And then we went about making sure that we had two sets of teams set up. One was working with the compliance and the technology, and we were pretty good with that because we'd been working for 13 years, so we kind of knew all the protocols. But the second part was the challenge, and there all these things come up. Fragmentation, no adoption, no interest. So what we did is we took a route that we are very familiar with in Plus 91, and that's becoming friends with the active users within what we hope will be the ecosystem. So whether it's doctors, whether it's nurses, whether it's lab owners, whether it's hospital owners, lab technicians, phlebotomists, these kind of people, because these are the active users. You've got insurers, you've got pharmaceutical companies. These are passive users according to us. So we started actually having a lot of interactions with them and trying to understand what they thought of ABDM. It's called NDHM that time. And whatever ideas we heard from them, we shared our ideas that we thought that it's possible that India can transform. And then we simply asked the question, what do you think? And that what do you think was very powerful because it led to honest conversations. And then whatever conversations we had, we put in a team over there to sit down and try to learn from these people. We built an expert panel of advisors to us from these set of people, doctors in slums and all who actually could become advisors to us. A person who's running a lab through a mobile van and going through, Kolhapur and all, that is the person we wanted to learn from, that what is it that you want to do. So we set up an expert pool of people who are advisors, and we set up an expert pool of people who become experts at understanding and trying to solve problems. And these guys would only do prototyping. So a lot of work we do is prototyping, trying to solve a problem, learning that the problem is half-baked, solved, and understanding and moving forward. We believe no product is ever complete. The day the product is complete, you can assume that it's dead. So the thing is, that's the approach that we took to find the problems.
So before I move to Deep, I'm going to ask you a tough question. It doesn't have to be a yes and no answer, but let's keep it brief. So with the implementation of ABDM at a national level, okay, the way it's going, do you think we are moving in the direction of thinking and working backwards? Like you said, your mental model was from the customer and then building for the doctors and the nurses? Or you think we are going excessively top down and ramming this down, and which is now leading to this whole challenge of lack of adoption and various gaps in the ecosystem? Have we really done a good job of studying the ecosystem and then working backwards? And I'm going to ask the same question to Suhail in a bit. But
sure. So see, the thing is, I am not qualified enough to talk like that because I don't run NHA. Okay, I run a small company which basically tries to help certain people do better with their lives. So the thing is, in my context, my approach, our approach is what we took.
Okay.
But as far as NHA is concerned, I can't fault them because at the end of the day, it's very nice to look at problems looking backwards.
Yeah.
See, the thing is, as long as you're moving forward, I think it's good.
Okay.
So,
okay.
My opinion.
So on the theme of working backwards from the customer, that is the philosophy of Amazon. That's how we have built all our services and products, and that's how we engage with our customers. So I'm going to go to Deepthi next. Deepthi, sorry to keep you waiting, but just setting the context. So if you can help us understand, Deepthi, what is the secret sauce of AWS developing the entire startup GovTech ecosystem and us enabling innovation at scale?
I think you already set the context well, Samarth, on that. It's the entire working backwards from customer need philosophy that Amazon has as a group, right? That same secret sauce is also behind the entire GovTech motion that we came up with. So, about 4 years back when I started working on the various smart infra projects and I was interacting with different customers, the customers were saying, customers don't really they don't really have to worry about infra. What customers really need is the business problems that need to be solved, right? So, be it in healthcare, the problem statement being that how do I take care of expecting mother's health and getting right parameters monitored, and how do I ensure right healthcare services are provided to her? Or if I look at agriculture domain, then how do I ensure that right advisories reach the farmers, or I'm ensuring that right quality of seeds, or someone is claiming that food is organic, indeed for organic food is being produced. So the government customers, the public sector customers are asking for solutions, innovative solutions to the business problems that they had. At the same time, when we worked with another set of our customers, the builders, be it startups or technology companies who are working in impact area, they talked about, okay, I have a very good solution. So again, the first example I talked about in healthcare, a very interesting startup called GeoVio, which has these tribal jewelry designed watches, IoT watches, which expecting women can wear, and the health parameters get monitored centrally and things like that. But they had limited reach and scale. So when I looked at the needs of these two customers, sets of customers that we had, right? So the government customers, they needed startups as engine of innovation, and the technology companies or startup customers, they needed government as engines of growth and scale. Yeah. So that's the genesis of the entire thought, that why not create mechanisms that brings these two together, and look at the tacit or unstated needs of these two sets of customers, create mechanisms on how these two can be brought together, and government gets innovation and startups and technology companies get scale. So that's how it all started. Essentially, it's all about working backwards from customer need. Is what
Interesting.
I'll say.
So working backwards at the core, and then mapping extreme levels of innovation, which is triggered by startups, and giving them the launchpad of government organizations who can enable scale. That
Yeah.
is how we've conceptualized the GovTech model for AWS.
Yeah, that's how we conceptualize. And what we essentially did was, every industry that we would pick up, we would look at doing an industry reference architecture. Identify the domain blocks that is really required to solve problems of
Right.
that industry, and then go back and map. Are there technology companies or startups that fulfill these, and what intersection they fit in, and then accordingly then go back and match those customers and
Problems.
government entities and startups and things like that. So yeah, so that was the entire approach that we took behind developing this program.
Yeah, I think verticalizing it around domains definitely is a secret sauce. We are very domain obsessed. I'm going to continue on this thread of conversation. It's building up really well, and I'm going to go to Rajesh ji now. So again, tough question, but it's in sync with how we are discussing. So we are talking about adoption, challenges in adoption, and how Sohail set the context by saying that that's one of the 3 problem areas where we need to solve. Now, eSanjeevani has been hugely successful. I think the numbers say so, right? I read on your profile, we've done 6 crore consultations till date.
That's correct.
And what's our monthly number of consultations?
So 2.25 multiplied by 30, 31 every month.
35?
That is around 60 lakhs plus.
60 lakhs plus consultations a month.
Yeah.
Now, by any means, if you look at that number, that shows that this model is moving in the right direction. There is uptake, and it is, at least the numbers are suggesting there is adoption.
Obviously. And
So what is it that we've done right to achieve this?
correct. So again, the interesting part of it was, for any government project. Otherwise, it is the intent has always been from the quality perspective. It is unlikely, in some context, it is the quantity game as well. But having said that, it is probably for the first time a solution by the government of India, which you would be surprised to know. In fact, when we did that, when we started that, we were surprised. Oh, they want us to do this? Are we sure? Okay, let's see. Let's go ahead. So the things were, starting the OPDs 24/7. Imagine. I mean, even after the core pandemic period was over, even after the second wave has gone third was on and the anticipation for fourth was on. But still, I mean, around 75% of the health facilities were operational again, back in almost full capacities. But still, during that time, we had at least 4 states to adopt this kind of approach, where they ran 24/7 OPDs. You would be surprised to know even a couple of states run it right now 24/7, even when everything is open. So that's an indicative of the kind of the demand, the adoption by the practitioners, and again, everybody at least get at least a day off, be it the 15th of August or 26th of January. eSanjeevani has this distinction where it runs 24/7 by 365.
But quick check in there. Is that because the doctors have adopted the platform and they want to consult on eSanjeevani, or is it a lot to do with top down, like the government mandating the states and the doctors to use it?
So it is both ways. Primarily the top-down approach to start with. I still remember way back in 2019 when nobody ever even have thought about or even heard about the word pandemic, and was the things were in their normal flow. But with the kind of innovations, the kind of improvisations in the government setup the current government is pushing across. I still remember the JSC Health at that time conducting a national level workshop here in the New Delhi itself with all the state MDs and directors, NHM respectively, and the actual the users. A lot of doctors were there, and they were debating the same thing, that whether it is the right kind of a approach, because even before the eSanjeevani OPD, the conceptualization of a national teleconsultation platform was on the cards, given the context of the entire ABHWC theme, which was started in 2019. So during that, there was a lot of apprehension, a lot of resistance from the doctors not to, going forward with this approach. But yes, during that time, it was the top-down approach, along with a little bit of stick, of course, and a little bit of mandation from that date, 2 teleconsultations a day. But having said that, the trend has changed because of the adoption by the end user themselves. So you would be surprised to know that apart from the patients, right from the rural background, even well-known fact that even a rickshawala today carries 2 phones, and the kind of adoption we wanted for eSanjeevani ABHWC wasn't that progressive what we got in eSanjeevani OPD.
Okay. Sure.
So yes, since there is a system now where if you don't give the services to the citizen, they will raise the issue with the right stakeholders in the government. So there is a mechanism where the things automatically sets in place when there is a demand, and even if the practitioners is not there, that is another topic of debate, where the actual users or the CHOs which wants to connect to the doctors, vis-a-vis their ratio is not as it should have been to upscale the potential of the entire solution.
Okay.
But yes, it is the both way around.
Sure. So Nrip, are you thinking that we should have probably done a telemedicine platform rather than HMIS right now?
So we also have a
I'm just
telemedicine
joking.
concept, but the thing is such an interesting point, because we always think this is one side is push them top down and go customer. Why can't we do
But
both?
what challenges are you facing as Plus 91 in scaling the solution in India right now?
So in India, see, the 93% of mom and pop shops within this particular ecosystem is the number one challenge that you're going to face anyways. Everybody thinks differently. And it's one thing when you're dealing with a large corporate. When you're dealing with a bunch of entrepreneurs, anybody will know that each entrepreneur thinks they know best. Okay? Same thing with doctors. They all know best. They know what they want. But they can't explain it to you, so you have to build custom solutions. Secondly, as a tech country, India, we've got a dime a dozen, companies building solutions, and at different price points, at different feature points. Some of them solve the problem, some of them don't solve the problem. So what happens is that navigating this fragmented ecosystem is possibly the biggest challenge.
Okay.
But besides that, I think what I've seen post the pandemic, there has been an uptake in adoption.
Okay. So you are enthusiastic about scaling in India.
Yeah,
Okay.
definitely.
So I'm going to go to very quickly to Preetham, and then I'm going to come to you, Sohail, because we need a deeper and I need your point of view on this. But Preetham, to you. So two things. Firstly, how is your solution fitting into the larger vision of digital health? Secondly, what challenges are you facing in adoption and scaling?
Right. First thing is technology in general, particularly AI, are agents for democratizing resources. So AWS does that with infrastructure. Likewise, AI will democratize access to world-class radiology by doing three things. One, providing access to radiology where it isn't already available. So we are now deployed in over 60 countries. More than 40 of them are LMICs. We are deployed in the ruralist parts of Africa and foothills of the Himalayas, you name it. So the technology is not the problem; it can reach there. So that is the first aspect of it. The second aspect is that we are making radiologists more efficient, thereby increasing the throughput, so that they can either spend more time with the patients, or do more scans in general. The third aspect is that we are building workflow solutions, so-called care coordination solutions, so that the information that is required is available to clinicians in a timely manner. Basically, making healthcare affordable, accessible, and timely through AI.
Okay.
That is the first question. Then, in terms of adoption, like everyone pointed out, like I said, we had to integrate with more than 100 health systems to reach the scale we did.
Sure.
That is the biggest problem. The second problem is that medicine, healthcare in general, is very slow to iterate. Now, when there's a new digital, so Western world is still stuck with CTs and their corresponding CT-based protocols for stroke and other diseases, whereas we've jumped the ship and adopted MRI, and we are now using MRI-based protocols, right? Likewise with UPI, we do not have PayPal or credit card adoption as much as the Western world, right? So we should not follow the path of the Western world in terms of taking the slow and long and arduous journey of digital transformation. We have an opportunity to figure out what is best, and we should not get into the rut of being overly cautious and overly conservative.
Okay.
I think that is an approach that the GO is already taking, but we'd like to see it more concretely.
Got it. So very interesting. Cure has taken the path of going very deep into one problem area, and they are solving for scale through integrations and being probably getting better and better. And it's an AI model, so it's getting better and better at what it does, and that's probably how they're thinking about scale, right? Plus 91 is looking at building the solution, working backwards from the customer, and iterating very quickly, and then aligning yourself with what the government wants to do. And eSanjeevani, on the other hand, is already at scale. And from what I know, we are thinking of building more features and more product use cases to make eSanjeevani more and more relevant. So I'm going to come to those use cases, what those use cases are in a minute. But Suhail, I want to come to you now. We've heard these three interesting points of view around the theme of adoption and fragmentation, right? If we have to go towards this vision and goal of becoming the digital health superpower, like Nrip's example of is having achieved that in, let's say, in fintech, what are the lowest hanging fruits that will solve for this? That's one. Secondly, are you seeing a dichotomy in if there's a government-aligned health informatics platform, the way it is scaling vis-a-vis point solutions? So on both these topics, we want your point of view, because
Sure.
you see it closely from the ground.
Yeah, so, if you have to just step back and try and connect a lot of the issues and opportunities that we just discussed, let's start with eSanjeevani, right? I think the point on inclusion, access, and Rajesh and I were in UP last week at a health and wellness center that uses eSanjeevani platform connecting to a specialist at the CHC or the district hospital. The closest secondary care or tertiary care facility was 18 kilometers, right? What we are not factoring in is all the other benefits, out-of-pocket expense reduction, etc., that is coming in. So that's, you could argue, can happen independent of all the other big plans that we have as part of the Ayushman Bharat Digital Mission. But the challenges that we heard from Preetham or what Plus 91 has been experiencing, I heard you say this twice now, 100 plus application integrations, and I'm sure that's a fraction of the number of health applications. So the fragmentation is not just a provider space, but also on the health solution space. ABDM as a construct, first of all, helps us solve for that. Once we have a ABDM compliant solution, data information flow should be seamless. It also makes sense for organizations like Plus 91 and the solutions that they're developing to bring that value to the consumer or the patient here. But also importantly, the point that you raised on how do we look at, this, I don't see it as a dichotomy in that sense. I think there is a responsibility that the government has today from a public health standpoint that will continue to be there, both from a provider perspective, but more importantly, hopefully adding value to the work that QRAI is doing by bringing in more aggregated, anonymized data that we should be able to leverage, right?
That's a good point. Yeah.
And then finally, in terms of just on the point on how do we do this entire ecosystem approach going, as I said, ABDM is a construct, right? It's not a platform. But till the time we are maintaining the principles of I am the owner of my health data information, and the construct allows me to build that consent layer and maintain that level of privacy if I wish to, we should be able to accelerate this adoption piece. Yes, you have to still answer what is in it for me, for a doctor, for a lab technician, and that's where we have to constantly innovate. And that's where I feel organizations like AWS and many more should come in and support that innovation piece so that we are able to build this together, bring it together as an ecosystem, and hopefully achieve what we have. We do have a late mover advantage in that sense, so we have the luxury to learn from the other mistakes.
Interesting. And Deepti, I want to bring you in on the point that Sohail just made. Organizations like AWS can jump in and help accelerate innovation. How? How do we help accelerate innovation to help the digital healthcare ecosystem of India? And there's so much that's going on.
So, first of all, as AWS, what we do is we reduce the risk of failures of innovation. As Jeff Bezos famously says that for every new idea to come in, for every one idea to be successful, you have to do, many times more, 20, 30 experiments that fail for one new idea to come in, right? So I think that is something that AWS provides for technology providers, developers specifically, a platform that allows you to fail safe, fail fast, experiment and do things. And I think second thing that we do is, as an organization, the field presence that we have, the kind of priorities that we have when we work with government mission mode projects. I think what we also do is kind of create that glue factor. Initially when I talked about the industry reference architecture, the domain blocks that we have, right? When we look at complementary sets of solutions that are required to solve any given domain that we look at, right? Like, I know that quite a few startups that we are working with are now getting into the eSanjeevani platform.
Yes.
That kind of really puts a multiplier effect to innovation that's happening on the field. Because when people get visibility of what is really needed from the government, those needs get communicated, they know a platform where they can go and plug in the scale that they're able to reach. It encourages a lot of other people to innovate and come and join those mission mode projects and go on top of that, right? I think that's another second very interesting factor. I mean, I typically look at any impact area sector that we work with. I look at any innovation as a three-legged tool. For it to be successful, you need to bring three types of entities together: government system integrators and say startups or builders, right? Because government, the large mandates that they have, they do any of those domains, they need multiple types of solutions to come in to fulfill the need. Again, healthcare, we have some six sectors, six verticals that we look at within healthcare. Now, there's no one startup or one solution that here itself may be here two very distinct kind of
Yes.
solutions that are getting built, right? E-Sanjeevani, distinct kind of that's getting built. So, so government, if you look at it, they do need those large system integrators who can bring these diverse set of solutions together, right? System integrators, their core capability is how do you stitch solutions together, and they don't really innovate on their own. But startups, they innovate, but they need to work with larger ecosystem to get it together. So as AWS, we look at how do we glue, how do we bring these three players together.
Very interesting.
So I would say that how we really act as force multiplier in the entire innovation ecosystem is one is our platform allows innovators, builders to fail fast, fail safe, do as many experiments, as many innovations, as they can do, focus on the core business differentiator and not really worry about infrastructure heavy lifting. And I think second key factor is how do we bring various players together, the holistic view and bringing government system integrators, multiple startups together, gluing it all together. I would say that's the second thing that really helps take innovation to the next level.
Very interesting. Yes, completely second that. And since I've been working in digital innovation with a lot of the startups, I know that's exactly what we try and do. Accelerate innovation on our platform, leveraging our services, and then bring in the force multiplier through our integration capabilities with our partners. Agreed. I'm going to do a last round of conclusions, and then we wrap up. So I think the theme here is I want to continue on it, and then I'm going to come to Sohail in the end to conclude the session. So I'm going to start with you, Rajesh ji. Just picking a point and just quick 10-20 second replies because I've been given a time check.
Sure.
So we've heard how AWS helps accelerate innovation. For eSanjeevani, how have you seen that in action? Very quickly.
I wanted to interrupt two of you many times in the between, but just to acknowledge it, had it not been for the CSP like you, there were many components at that time, which were on the fly, was available on a platform like this. Otherwise, the things which the government wanted us to do, we would have ended up, coding a lot of unnecessary things which was on the fly, was available on the platform. So that part, the CSP has already played it. But again, having said that, the innovation or the next road ahead for eSanjeevani is very simple things which we want to do, because the government has already set the agenda for us in terms of integrations, in terms of inclusion of the startups and the other triple P mode inventions which are already there on the field, although in solos. So that platform is being now very perfectly being built up with these three ecosystems in place. ABDM, everybody had said, and that top from the topmost layer which is coming around of the unified health interface. So I think with that is in the action mode now.
Sure.
But as far as the eSanjeevani is concerned, we want to do very simple things. I'm not very sure how correct is this fact. The learned members or the august audience can, if they are aware of this. I have heard that in UK, you can't go in for a, direct doctor consultation if you want to. They have some kind of a robotic system or teleconsultation system where you first do, and then they assess that robotic solution assess whether you actually need to see a doctor.
Right.
So we want to do, it sounds very, sort of stupid in Indian context, but yes, we want to bring that revolution in.
Sure.
Where every consultation, because you visit, forget about government innovations, government processes.
Sorry, I'll have to do a time check, but quick conclusion.
Yeah. So even if you go to a private hospital for a consultation, you wait there, you pay there heavily, you wait there, you still don't get your consultation done on the time. So we want to change all that scenario where, eSanjeevani can play a role where you can have the roles of all the stakeholders balanced in, that approach.
Thank you. Rip, quickly from you.
I agree with whatever Rajesh ji said. I agree with what Deepti said. I think one of the things is, as far as AWS is concerned, without AWS, we'd probably be 10 years behind. Lots of things get done because AWS has tools available, things like API, Gateway, Lambda. They just make things happen fast for us. And so you know that you don't have to worry about some of the infrastructural pieces or the technology. It's going to happen.
Taken care of.
Yeah. Second thing is that the ecosystem is very, very beneficial. You get to meet people who are smarter than you and you learn from them. That's very, very amazing.
Sure.
And finally, at the end of the day, what happens is that a lot of people might not understand this, but when you have a really good, solid platform, like whether it's, I mean, you have competitors, I know, but AWS or Azure or Google Cloud or whatever, when you find like 100 companies working on them, integrating between them becomes
Right.
easy. And the thing is that integration is the only way you can build an ecosystem. You can't build an ecosystem standing on your own and saying, I'm everything. So that's how
Perfect.
AWS helps us.
Thanks. Great. Preetam?
Yeah. So obviously we have very high, HPC needs, and AWS has been instrumental in building our HPC cluster and then the infra that is required for training our algorithms. But the second aspect is deployment, right? So with GDPR and all of these data protection laws, there's a lot of compliance that we need to do. Even in the UK, we are heavily deployed in NHS, almost 30-40 trusts use NHS, use Cure.ai. But for them, they ask us to deploy on-prem, and it's not an option for us because we'll not have access to logs and all of that. But the moment you say that, okay, can you provide a AWS VM for us, and we'll be able to deploy there. So that makes it significantly easier. There's the trust element of AWS that is coming in tagged with Cure, so that they're much more comfortable to share the data to the cloud.
Got it.
That is one big aspect that I think is very special to us.
All right, we are at the end of the discussion. Sohail, I'm going to ask you to conclude, and in whatever way you'd like, and that will be the...
I'll actually just take 10 seconds. So I have two requests. One for the panelists here and some of the health tech providers out there, continue to innovate. This is a great opportunity. And the second request is to all of us as consumers of health services, just demand going forward that you want your data information, it's yours.
Yeah.
On whatever health locker you want, personal choice, but demand it. This has to be now a movement literally for us to demand what is our right.
It's music to Rip's ears. Thank you so much. Thanks everyone. Thank you panelists for a really engaging conversation. I had a great time hosting you. Thank you.